morning, good afternoon, everybody, depending on which part of the country or countries you guys are located in. Today, we're going to talk about removable pros, about not just occlusion, not just about setting teeth, guys. Um, I have done this lecture before, yes, but every single time that I do it, there's always something new that I try to mention. And there's some more questions usually that come in, and we try to kind of answer them. I'll be honest with you guys. I've been doing this for quite a few years, but there's still so many things that I don't know, and there's so many things that I keep learning every single day. And I try to share those things with you guys. Um, so if you look on your screen, you'll see my wonderful AI generated picture, because I don't even own that suit, and a QR code. Now, this QR code has all my social media information, so I post a lot of videos on Instagram. If you guys want to take a look, talks about this kind of stuff: implant support, tissue support, prosthesis. And today's lecture will include clinical and lab. And I'm a firm believer that you cannot, with any grade of success, do removable pros if you don't understand both aspects of things. Majority of the things that I run into while I work as a consultant with the University of Utah general practice residents is the fact that they don't have a very good understanding of what lab aspects are. And a lot of times I have to kind of bridge that gap just so they know what they need to do clinically in order for the lab to have the most successful outcome. So a lot of times we do things that are not exactly laboratory, right? Because lab technicians are no longer just bench techs. Well, not all of them, but majority of lab technicians that are removable are not just bench techs. A lot of times the doctor will call and go, listen, I'm trying to get this done for this patient. What do I need to provide to you in order to have the best possible outcome? So we have to be consultants, and we have to know all the steps in order to have the best possible outcome. Okay. All right, let's move a little bit forward and see what we got there. So this picture is one of my favorites. Unfortunately, I didn't take this one myself, but it really brings home the whole aspect of, if you do not have a good foundation, if you do not have a stable foundation, you're going to have a very, very difficult time to get a stable structure. No matter how beautiful it is, if it's got nothing good underneath it, it's all going to fall apart, right? Or we'll need something done in order to get things fixed. So common issues that we see in removable pros, right? You don't have enough lip support, or you have too much lip support. We don't have stability of maxilla and mandible, especially mandible, guys. We see that very often. Insufficient buccal corridor is one of the issues that I kind of have to talk to my clinicians and give them my 2 cents on the subject. And that 2 cents is, buccal corridors are great, and you want to bring out and maybe fill in those black triangles as much as possible for your patients. But you need to understand model analysis. You need to see what and where you need to place in order to have the best possible functional outcome. Because if you take, for example, on the maxilla, and you see that the patient has a lot of resorption, on the maxilla, resorption goes from outward, inward, and up, right? So if you had lip support, all of a sudden you don't have lip support, and the ridge is becoming short, and the same thing on the outward. You're going to lose that buccal corridor, increase that buccal corridor by losing that residual ridge. And if you want to fill it back out, aesthetically, yeah, absolutely, you can place those teeth out as much as you want. You know, it's going to look aesthetically great, but functionally it's not going to work. Two things will happen. Number one, denture is not going to be stable, because all of a sudden you're not placing that force on the crest of the ridge. You're putting it on the sides, and it's going to teeter-totters on you. And the second thing, it's going to be a lot more prone to midline fractures. When I speak with clinicians and we talk about, well, this patient comes in, she has a midline fracture, we repaired it 2 times, and it still keeps fracturing. I said, well, take a look at where the teeth are set. Are they set on the crest of the ridge? Or especially once you start getting to the first and second molars, are they set off the ridge? Okay, well, they're set off the ridge. Well, there's 2 things you can do at that point, right? You can maybe take it out if it's like it's got semi-anatomical occlusion where you have ABC contacts. Maybe try to take out all the buccal contacts so you're just functioning on that palatal cusp, and maybe that will bring the forces closer to the center. Or if that doesn't work, go ahead and reset and redo the dentures. Yes, you will have some compromise on the aesthetics, but you will have a functional denture. So you need to be able to balance your aesthetics and your function whenever you're dealing with removable pros. It's a it's a full mouth restoration, guys. So it needs to be approached as such. Okay. As I mentioned before, communication is key. You have to talk to every member of your team. Like if you're working on a complex implant case, so you need to be able to communicate with the surgeon, the prosthodontist, or the general dentist, or the denturist, and the lab. Okay, all three teams, all three members of the team need to be communicating with each other, and you need to have photographic communication. Uh, I always say there's never too much information you can give me, because if it's something I don't need, I'm not going to use it. But if it's something I need, I'd rather have it. Okay, things like this. So digital communication, written communication, educating your clinicians if necessary, asking your clinicians to educate you. Okay, ask them what makes it difficult to do this on their end, and seeing what you can do to make their life easier, and vice versa. Okay, maxillary impression. So to me, whenever I'm dealing with, we're talking about tissue supported cases right now. Whenever I'm dealing with a regular tissue supported case, I still need to have really good and stable foundation that we guys talked about, because it's very difficult to fix things down the line if you do not have all the proper information. So a really good alginate is a must, folks. Okay, you don't know how many times I'll receive an alginate from a clinician, and it'll just be like half the ridge, or something is missing on the lingual, on the mandible, and things like this, and they'll be like, please fabricate custom tray. And when I try to communicate and say, listen, I really don't have much information here, such and such, and they're like, well, it's just for custom tray. Do you really need all of that? And the answer is yes, because if you do not have all the information that you need to make a good custom tray, you're going to have a difficult time fabricating a final impression. And you're going to have to do some kind of alterations to the custom tray. Now, if the custom tray is slightly short, you might have to build those areas up with compound. But just this morning, I was talking to one of the residents, and I saw the custom tray that they had, uh, which was made from the initial impression. And the tuberosities were missing, the handler notches were missing, the soft palate areas were gone. And they're like, well, a patient's a gagger and everything else. Well, if you have a patient that's a gagger, you need to address that issue right from the start. You can't just be like, well, they're gagging, we can't get a good impression, let's just do the best we can. Well, first of all, there are ways that you can manage gagging on the gagging of patients with certain techniques, right? You can do psychological exercises that can help things out. You can have your patients lift their legs up while you're doing the impression, have them pull on the towel. My favorite psychological trick to use with patients is when I do the maxillary impression, is to tell the patients, do whatever you want, but just do not think about pink elephants. That's my favorite thing to say to them, because they're just sitting there like their eyes get super wide. They're like, what the hell is he talking about? And they concentrate on the pink elephants versus their gag reflex, and we're able to do that. But if those things do not work, you need to have a conversation with your patient. Say, listen, you have a fairly severe gag reflex. Fabricating a tissue-supported prosthesis and have it be retentive is going to be very difficult. So there's things that you need to be aware of. If we fabricate this denture, there's a high possibility we're going to have to take out the palate on it, or carve out at least the soft palate area where you have the suction part, so you don't end up gagging, and you're probably going to have to use adhesive. The second thing is what I generally recommend is doing implants, and do implant supported prosthesis. That way we can maybe do some splinting between the implants, and then do some kind of reinforcement with the denture, and then maybe take out the maxillary palate in order to give the patients the best possible outcomes. You have to be careful with maxillary implants if you're doing like four locators, for example. If they're not splinted, there's a higher chance of losing those implants if you cut the palate out. So that's also something you need to address with your patients. So things like that. So when I'm taking my initial impression, I want to make sure that's a nice overextended impression. Why do I want to have a nice overextended impression? Because I'm going to use those overextensions to judge where my muscle attachments are, where my buccal mucosa is. And I'm going to make my trace from that point out. Okay. Okay, on the mandible, similar things. We need all that anatomical information in order to give us the things that we need to fabricate the custom tray. As you can see right here, I know that the buccinator muscle attachments are here, the masseter attachments are here. I can see that little sinew attachment there that I'm trying to avoid. All the frena are visible and make things a little bit easier for me, okay, to fabricate those trays. And we'll talk a little bit more about this. So I see things like this, oh, patient was a gagger, that's the best we could do, make us a custom tray. It's going to be difficult, right? Because we don't have the necessary information. So that takes me back to the conversation that I just talked about, right? Talk to your doctor, see what you can do. Okay, maybe if patient's a gagger, you can't get this done, then we're going to talk about things like this. Maybe with this particular patient, you have severely proclined anteriors. You can't get the tray in all the way, and you're having issues. Well, maybe you're going to have to fabricate a split tray. Maybe you're going to have to do a scan for the initial impression so you can fabricate a custom tray. That's where the digital stuff comes in. Or maybe you're going to have to maybe do some extractions first. Say, listen, we're having a really difficult time with what you have. It will be a lot easier for us to complete this process if we extract your teeth first, let you heal up, and then fabricate a denture. And we also will be able to try your teeth in and make sure we're not creating any mistakes along the way. I don't like doing immediate dentures, folks. I'll be honest with you, because there's a lot, there's a lot of guessing when you do immediate dentures. Okay, I highly advise, if you can avoid doing immediates, please do so, because I've had a lot of issues doing this. I've had a lot of successes as well, and I attribute those to luck, not skill, to be honest with you, because we're just not able to visualize things as much. With digital, it's a little bit easier because we're able to upload the models, and we can actually upload the facial scan and line those things up. So when we're setting teeth, we can see a lot easier. With analog, it makes it really difficult because you can look at pictures, but you can't really line things up doing them in analog. So, and since we still do quite a few analog cases, I'm not a huge fan of immediate dentures. Let's put it that way. Okay. Same thing here, right? We have missing information. The entire tuberosity on the patient's left side is missing, and the hamular notch is gone as well. So I can fabricate a tray off of this, but we're going to have to do a lot of guesswork here, and guesswork usually equals not a proper fitting prosthesis. Okay. This is one of the most common things that I see when you're using dentate trays on the mandible in order to take the initial impression for your custom trays. Okay, dentate trays are created not to capture a lot of soft tissue, right? They're generally fabricated to take an impression of the teeth. So a lot of times, if you don't adjust the trays, you're going to end up with things like this, where you're actually pushing into retromolar pad, which is a fairly important structure because you want to have the best possible impression of that in order to make the best possible custom tray and to make the best possible final impression. Okay, and if you do not have the area of the custom tray, if the area of the retromolar pad, you're going to have some issues. This is not as bad as maybe something like this, where you ended up pushing into it and then also did not properly pour out the model, so you're missing all that information. Another thing, guys, when you're taking your impressions, have the patient close down their mouth. Don't take impressions like this, okay? Because what happens is that it actually stretches out the retromolar pad, okay? And it doesn't give you the best representation of what the retromolar pad is going to be, okay? Majority of people don't go around walking around like this, okay? They walk around normally. So you want to try to capture that state of tissue versus this one. And also, when you're stretching out your retromolar pad that tall, it makes it difficult for the lab to see what the plane of occlusion is like, because majority of us will go from the plane, and from the posteriors goes up all the way up to what? 2/3, halfway up, or 2/3 of the retromolar pad. Okay. Now, if you take a retromolar pad in its relaxed state and you go halfway up or 2/3, it's going to be one height. If you go from non-relaxed state to stretched out, it's going to be way higher. So now all of a sudden your camper plane could be off and stuff like this. And also when you set lower T too high, it can cause issues with stability. Okay, so all these things kind of play into each other and can cause issues down the line. I hope that makes sense. Okay, so what I'm dealing with a dentate tray, because what at the clinic that I consult at, all we have there are dentate trays. I have some of my edentulous trays there, but majority of the time we'll end up using stock trays to get what we need. So as you can see here, I ended up using some putty on there just to create like a tissue stop on the pallet and a bit of a border molding on there, just so I don't have to maybe cut a lot of the tray and stuff like that. And then on top of that, we ended up using alginate. I'll show you a little bit more about the alginates that I use and explain a little bit more down the line. Okay, but you can see that I got my hemular notches, I got my tuberosities in there, I got my vestibule. And what I generally recommend when you take your initial impression and even when you take your final or reline impression on dentures, look at the hemular notches and draw a line between those two hemular notches. Generally, that's how far back I want an impression of the soft tissue in the mouth. Because if it goes like this, it's not really going to work well for me. So let's say, for example, I take this point and I take this point and I draw a line. Well, this is how far back I need. So all of this I don't really need. But let's say if I have this line, but my impression kind of goes like this, the semicircle, well, now I don't have enough information for what I need. And I might need to either retake this impression or I will have to add compound in that area for when the custom tray is fabricated. So all these things you have to understand and you have to kind of adjust for them down the line. Here I also used a Thompson indicator stick to mark the soft palate area. It's not always necessary for initial impressions. Sometimes we'll use it for finals. But if I do it for finals, guys, those Thompson markers, those indelible markers, they're not very stable. So I'll go back in and I'll trace the area out with a magic marker with like a Sharpie. That way, when I'm disinfecting it, all that ink is not going to come off because this stuff will come off fairly easily. Okay. So on the lower, the things are a little bit different. If you follow Dr. Jiro Abe, he wrote a couple of really cool books about mandibular suction effective dentures. Now, I don't claim to know much about that system because I've never taken a course on it. I just read the book, a couple of the books actually on it. But some things are just pretty basic, and that's what I utilize in my workflow. And one of the things I do is I'll take stock trays and I'll cut them down. I'm just using hobby scissors and a torch. Some people don't like using a torch because it creates a smell. Patients don't like it. I never personally had any issues with it, so I don't mind using a torch to warm up the trays and then just cut them where I need to or stretch them where I need to. But I always do it next to a sink because if it catches on fire, I want to be able to put it out a lot easier. What you can also do is use different kinds of trays, and we'll go into it a little bit. Okay. Also, when I take my lower impressions to make things easier to pour up, a lot of times I'll use either R-time dough putty, or if I don't have that, I'll just mix up some alginate and fill in that tongue space. So it makes it easier to box up and pour up. Okay, as you can see right here. On this one, I actually used a little bit of the Thompson indicator stick because I wasn't the one that's going to be making the tray for this case. So I marked the outline, the myostatic outline for the doctor on the impression to make it easier for them once the tray is going to be, once the model is going to be poured up, to make it easier for them to fabricate a custom tray at the clinic. Okay. So two of my favorite algins to use are neocolloid and hydrogum 5. Now, obviously, you don't have to use this alginate. The reason why I like to use this is because neocolloid is the high flowability, as it says right here. It's the light body alginate, okay? And this one is going to be your medium or medium body alginate. So basically what I will do is I will take a 60 cc catheter tip syringe, which you can buy those on Amazon. You can buy dental ones as well, which are exactly the same, except they're dental, so they're going to cost, how much. So these catheter tip 60 cc syringes are great for when I mix up the alginate, and I mix up neocolloid, and I'll put it in there. And while I do that, the assistant usually mixes up regular alginate and starts loading up the tray. And we'll go in and we'll just inject into the vestibule and sublingually, and it gets really nice and deep in there, and it creates a really nice impression of it. Now for the mandible, if you can buy these are the frame cutback trays from Dr. Abe again. J. Morita Company, I think, sells it. And there's Chinese knockoffs of this as well. And as you can see, the areas of the retromolar pads, or leading up to retromolar pads, are completely open. And the idea there is that you want to be able to capture the position of retromolar pads undisturbed, just so you're not, because that tissue is very movable, and any kind of excessive pressure in that area will disturb it quite a bit, and they can really mess up with your suction down the line if you can achieve it. And if you look on the sides, you can see that all of this has been cut back, just so you're not pushing overly on the areas where the buccinator muscles are, where the masseter muscles are, so you can get a nice representation of where the attachments are and where the buccal mucosa is, things like this. And another thing you can see right here is the handle is bent. The reason for that is twofold. Number one, it goes up and then bends. It doesn't just go straight out. If the handle goes straight out and you go into kind of border mold, that anterior mentalis area, you're going to have a hard time getting it because once you start to move the lip up, okay, like this, it's going to end up hitting the handle, and you're not going to be able to get that very well. And the second thing is, you see that nice bent platform, so when you're taking your impression, you can actually have your patient close down on top of that and make sure you get your retromolar pads in a relaxed state. So really cool design of those trays. But even he talks about this in his book, says, you know what, if you can't get those trays, you can modify your stock trays, as you can see right here, to have the same kind of areas. As you can see right here, I bent the handle, so it actually creates a little bit more space here. Should probably cut this area out, but actually works out okay without it as well. Obviously, rope wax in the areas where you're cutting, because you don't want to cut your patients. It also kind of creates a nice little border molding area. And this is just the same picture I showed you guys before. It's just another view from the inside. Okay. Another thing you could use is just edentulous trays, right? From the Mossad system. And these particular ones are thermoplastic, so you can actually bend them and cut them down where you need to and take impressions with those. If you're dealing with dentate trays, a lot of times, like I showed you guys before, you could use just silicone or wax. If you want, you can use compound. In this case, I was using isofunctional. I generally just use green stick or thermoplastic beads nowadays, because it's, first of all, I like thermoplastic beads over green stick because thermoplastic beads are a little bit more flexible. So I have to travel with the case. If I have to ship it somewhere, it's a lot more stable. It won't crumble on you. Compound is kind of crumbly. This one might not be because it's a softer kind, but it's also the more expensive kind. But also be aware of doing this on patients that have mandibular tori or really deep undercuts, because compound works really well when it's soft and it goes underneath those tori. But once it hardens up, you're going to have a really hard time removing that. And also, your patients are really going to be upset with you. I actually found this out the hard way, not only on patients, but when I was going through my denturist degree, we actually had to take a bunch of impressions on ourselves. And lo and behold, I actually have pretty severe mandibular tori that I wasn't aware of. So I border molded it, and I went in, and next thing you know, I can't get it out. So I'm like, trying to put warm water in my mouth, and it just, yeah. So be aware of that fact. Okay. So this is an impression of lower. This is actually my impressions. I did these for school. As you can see with compound, you can get really good vestibules on things. Okay. So whenever I'm seeing patients, I'll go in
Just want to see what's going on.
and I'm going to make sure that I see everything that I need. I look at the ridge. I try to see where the muscle attachments are, buccal mucosa, how much ridge resorption there is, what I need to do with its trays. Because a lot of times I'll come in, these are not my patients, right? These are patients of the residents. I'll come in for consults and I'll show them, okay, let's take a look where your trays are. And let's take a look what we have in the mouth. Okay, are your trays too long? Are your trays too short? Every time you make a custom tray, you need to be adjusting those things in the mouth. Okay. Okay, custom tray designs, closed tray, space tray, window trays. Okay, so which custom tray design should you be using, guys? It's very kind of opinionated field. And a lot of people will swear that this is the only method that works, and the others say, you know what, this method is way better than this one, and let's do it that way. Personally, I'm a proponent of using whatever works for you guys. If you want to do space trays with border molding and compound and do it that way, I'm absolutely fine with it as long as you get good results. Personally, I like to use close fitting trays. I don't like to do border molding. I like to get it as close to the border as possible and do one and done kind of thing. So border mold and impression all at the same time. Um, Sometimes if I'm having a difficult time, I'll cut back and maybe I'll border. Okay. And window trays are usually for cases where you have severely movable tissue, especially in cases that it happens a lot is Kelly combination syndrome cases, where the patient is fully edentulous on the maxilla and has distal extension, edentulous on distal extensions of the mandible. So they'll have a lot of forces where they actually are occluding into the anterior maxilla with their opposing teeth, and it causes a lot of inflammation, bone loss, and just tissue overgrowth in those areas. So we try to manage it a little bit with tissue conditioners, but a lot of times you will have to actually excise that tissue and use a window tray in order to pick up those areas so it's not distorted, so you have really good suction on those things. Okay. Also, different materials will require different thickness, right? Now, if you're going to be doing like a final impression alginate, obviously you're going to have to need a lot more room versus regular polyvinyl. And this, polyvinyl and zinc oxide eugenol paste usually have about the same um, areas. It says here like silicones are like 1.3, and this says 0.5. Honestly, guys, 1 millimeter will work for both. I use polyvinyl most days. I don't, and I do a 1 millimeter spacer with some tissue stops, and I usually get really, really good results with that. Okay. Now, majority of us that when we go to school and they tell us about how do we need to be designing custom trays, I hear this when I went to dental assisting school. I heard this when I went to denture school. I've heard this as a tech. I've heard this as well a lot of times. You need to go to the depth of the vestibule and minus 2 to 3 millimeters from there, and that's where your custom tray needs to be. Well, I hate to break it to you guys, but on the maxilla that might work. On the mandible, unfortunately, that's not the case, because especially when you have um, overextended initial impressions, they go down quite a bit into the mucosa and things like this. So a lot of times your depth of the vestibule is going to be your distorted mucosa and not your buccal shelf. Okay, and then you're going to be measuring 2 millimeters away from that. You're still going to end up with an overextended custom tray, and that's why I always recommend double checking everything in the mouse. Put that custom tray in there. Look, see if it's touching it. If you can't see if it's touching it, put a little bit of ultralight body impression material without adhesive on there. Go through the movements, see if it's hitting the tray. Adjust the tray there, okay? And also, if you have an overextended tray or if you have a close fitting tray, right, where you're like almost right at the margin where you need to be, right at the muscle attachment where you need to be, don't use compound there because you're going to overextend things with it. So all these things need to be aware of. And you, for my lab people here, when I say lab people or lab guys, I don't try to be gender specific, guys. I just don't know anymore which are the proper things to say, and so if I screw up, I apologize. I don't do it on purpose. Uh, when you get a phone call from a clinician and they go, you know what, the impression was holding it so great, and the denture is not really fitting really well. Well, oftentimes, especially on the mandible, what's going to end up happening is that your impression is going to go below the mylohyoid and it's going to engage that undercut, so you have really, really good retention there. When we're making a denture base or a try-in denture base for wax ram or for setup, 9 times out of 10, those undercuts are blocked out. Okay, so it no longer has that retention, because if it did, you wouldn't be able to get it in. And if you got it in, it would be really painful. So obviously that undercut is not engaged, and now all of a sudden you're pushing on all those muscles, and it's actually just throwing it out in the wind. So being aware of a myostatic outline is really helpful in order to properly design your trace. Now, this is just a guideline, guys. It's not a final thing. So if you mark it out and you're like, okay, this is great, and you go in the mouth, that's not going to be perfect every time. It's going to give you a nice start, but you still need to adjust your trace chair set. Okay. So obviously not every impression is going to be the same. So like I showed you this one before, like it's a lot easier to work with versus this one where everything's kind of pushed out and you're like, where are my frena at? Where's my buccal shelf? I can't tell where my mucosa is versus the muscle attachment versus the residual ridge versus all the other stuff. So that's why that step that I showed you guys with Hydrogum 5 and Deocolloid actually helps out, because chances are this was actually, I can tell this one was done with silicone, and probably heavy body silicone, which kind of pushed on everything and just kind of pushed everything out of the way, so you can't really tell what's going on. But on here, let's just say you took a regular alginate with just Hydrogum 5, as you can see right here. Now you can see some definition, but not very good ones, right? But if we take the same patient and we do a dual impression with Hydrogum 5 and Neocolloid, now you can see a lot better, right? Now you can see all those little fibers in there where the mucosa is, and then you can actually pour those things up. Here I'm using frame cut back tray. I see a little bit of show through there, which is not a big deal, but you need to be aware of. But from that tray, when you pour it up, now I can see a lot better in that area. And it shows me, okay, well, this is where my masseter and the buccinator attachments are, where this is when buccal shelf starts. But if we go back to our denturist school, lab school, dental school, whatever you want to go, and you go, okay, depth of the vestibule and 2 millimeters. Well, my depth of the vestibule is right here, okay, on this impression. Depth of the vestibule is right here. So if I go 2 to 3 millimeters from here, I'm still going to be overextended, guys. It's just as simple as that. And then if I'm going to go compound, well, now I'm going to be really overextended, okay? So here, you know, we mark the crest of the ridge sometimes just so you could say you did, I guess. I'm showing you these little things that are part of the myostatic outline the way they were taught to me. Honestly, I don't really know why you would mark the crest of the ridge, but maybe it'll just make it easier to see where the retromolar pads are starting. That could be one of the reasons. So you mark the crest of the ridge. I just mark the retromolar pads personally. Okay. You mark the mylohyoid ridge. That's important, right? Because you want your trace to be slightly below the mylohyoid. Okay. When I'm taking those impressions, and we talked about this already, I want to make sure I mark it below. So my denture is actually going to be about 2 millimeters below that mylohyoid ridge. That way I can get that nice compensatory suction in the lingual area and make sure I get nice stable suction for my denture. Okay. Okay, I'm going to mark the external oblique ridge on there. That's the area that, what's the word I'm looking for, guys? Sorry, let me go back. That's the area of where the buccal shelf starts getting into muscle attachment. A lot of times that area is kind of hard to see. So we kind of approximate it. Some people say if you take your model and you take a single light source and you kind of rotate your model to that light source, you can kind of see where the shadow starts to fall, and you mark right at that border. And a lot of times that's going to be your external oblique ridge. On other cases, I can kind of see it a little bit better, as in this one right here. I know that that's going to be right here. Okay. Next one is your mentalis muscle. For me, that's the most visible one. For my cases, even when the patient has severe resorption of the residual ridge, oftentimes you can still see kind of where the mentalis attachments are, okay? And we mark those because the denture is going to be, some people will cover that completely, some people will go about halfway up. I've done them both ways. I like to cover them about halfway up. I feel like it creates a better fit. It doesn't push things out. Okay, there. Okay, mark all the frena if they're visible, right? If you can't see the frena at this point, don't worry about it. You're going to have the clinician adjusting a chair side for you. Okay, if you have the lingual frena, mark it. If you don't have it visible, obviously you can't mark it there. But these things are pretty important, right? Because if you don't capture that in your final impression properly, and the patient moves their tongue forward, what's going to happen is that lingual frenum is going to engage and throw the denture out of bounds. Okay, so mark 1/3 of the mentalis muscle and connect it to the labial frenum. Okay, so 1/3 up and connect it to the labial frenum, as you can see right here. Okay, you can go 1/3, you can go half. I usually just go half. It's really difficult to measure 1/3, especially if you have a really small mentalis muscle. So I just gotta bisect it and I connect it. So that's gonna be my anterior portion of my custom tray. Okay. On here we see that we have my mentalis muscle, this frena, and we're gonna attach it to the buccal frena if it's visible. The next thing we're going to do is we're going to connect our mylohyoid ridge to the retromolar pad. So we marked the mylohyoid a little bit below it actually, and then our retromolar pad we're going to mark about halfway up. The reason we do that is because the retromolar pads are most stable in the lower portion. The upper portion is the area that usually stretches out, and a lot of times we don't want to extend our dentures all the way there. And I've done it before where I've extended it all the way to the top and I had to actually reduce it because the patients were comfortable. Okay, so that's something you guys can do on your own. Also, if you go and take it all the way up to the top of the retromolar pad, when you try to do the actual connection to the mylohyoid, you're going to start engaging this major undercut right here. Oops, sorry. This major undercut right here. And you're going to have to actually cut that out anyways. So what you can do is you can go higher here if you want, but you're going to have to go this direction. Still bring it down and go down. Okay, so that's one of the things you can do. Hope that makes sense, guys. I'm sorry, sometimes I will make a mistake and I'll start talking about the stuff fast. And because in my mind, I'm thinking, okay, these guys already know it. I don't need to kind of go it. I don't do it consciously. It's a subconscious thing. So if you see something you don't understand, please ask a question and we can, once we reach the end of our presentation, we can kind of go back and talk about it a little bit, okay? So here I'm just showing you guys where the masseter attachments are. So masseter attachment is going to be right here, and a buccinator attachment is going to be right here. As you can see, that's going to be our mylohyoid. That's the buccinator. And that's the depressor anguli oris, okay? So we try to avoid all these this muscle group of 3 muscles to make sure we're not impinging on it, because every time the patient is going to engage those things, they're going to throw the denture out of the way. Okay, so we can see right here we got mentalis, depressor anguli oris, we got our vaccinator, we got our masseter, and we have our mylohyoid. Sorry, I get confused there once in a while. So you can see we're trying to avoid, that's why you have this semicircle right here. We're trying to avoid our masseter muscle because it's pretty aggressive, right? So a lot of times I'll see dentures going to that direction and I'm going to throw it out. So this muscle and this muscle is the major ones that I see that really mess up my stability on the lower. Okay, so with this outline, guys, you can make a good custom tray. As you can see that it's sitting on the crest of the ridge. You can see that the buccal mucosa and the muscle attachments are not engaging. You can see a little bit that I have the sinew here that's also kind of being avoided. And that tray I'm going to bring to my patients. I'm going to try it in the mouth, and I'm going to make adjustments where I have a little bit of overextension. So on this particular patient, this area right here ended up being overextended. So I ended up taking out about 1.5 millimeters, 2 millimeters of that area. Okay. Obviously, we're avoiding the lingual frenum on the lingual area, and we're going about 2 millimeters below the mylohyoid ridge. Now you can kind of see right here. Remember I talked about if I go all the way up here, you're going to have all this area that's kind of undercuts, and you're going to end up having to remove that anyways. That's why we don't extend our trays that far back. Okay, so you get a closer look right here in this area. We see all the buccal mucosa, and we're avoiding that. So this is the actual video of this patient and tray that I just barely adjusted this area right here. And without anything else, from the initial impression, we were able to get suction on this patient and without even taking any kind of impression. Hindsight, yeah, see, great suction. Hindsight, what I could have done is just cut the handle off that tray, put it on the initial impression, and set my teeth up that way. It would have fit great. But what I decided to do, like a little wash impression with like ultra light body or light body, just to get all the little nooks and crannies and get even better suction on her. And we use that as a final impression. So that's the idea behind the myostatic outline. That's going to give you a lot better success with your final impressions and with your final denture, because you can have the best possible occlusion schematic in the world. You're like, oh, I got it right on the ridge. I got lingualized occlusion. We got no buccal forces. I'm in neutral zone. Everything's great. Yes, everything is great. Well, neutral zone, you probably wouldn't be in neutral zone if you overextend it. But if you overextend it, if you have great occlusion, the denture is still not stable. So you need to make sure you have good and proper impression for your case. Okay, so closed mouth impressions. Supporting tissues record in functional relationship. Wax occlusion rims are made out of preliminary casts. Border molding and the final impressions are completed. So this is one explanation for closed mouth impressions. So basically this talks about the BPS technique, which is a valid technique, which is actually a great technique. Unfortunately, I don't use it because I'm not able to follow the case through start to finish because I don't see a lot of my own patients. So we still do initial impressions, then final impressions, then wax rims. The way to do closed mouth impressions, the best possible way, take your initial impressions, take a centric tray, record the approximate, vertical dimension of occlusion. When you're fabricating your custom trays, make those with wax rims. Even better, make them with Gothic arch tracer and use that for your final impression and bite registration. Because patients get much better impressions, in my opinion, with a closed mouth impression. You guys ever notice that you get much better reline impressions than you do regular ones? Because patient's occluding. Patient can do all the necessary movements and have stability of the tray, and they can border mold things for you a little bit easier. So this is my favorite way of doing things. Open mouth impressions, because we were taught that way, a lot of us, and a lot of people like it because they can actually hold stuff in. They like that stability, and they can kind of see what's going on a little bit better and they make sure things are properly done. But to each his own. As long as the end results are what you're trying to achieve, that's all I ask for. And as I mentioned before, custom trays, there's so many different designs. As you can see this picture right here, I tried doing like a little demo where I've read about all these spacer designs. And trust me, guys, I've seen great impressions with practically no block out. I've seen horrible impressions with practically no block out, and I've seen horrible ones with great block out, and vice versa. So my personal favorite is the one on the bottom, where I just block out the undercuts and a little bit of the incisive papilla area and the rugae, just so I'm not overpressing it, and do a close fitting tray there, guys. That's my personal favorite. With partial impressions, a lot of times you have to be aware of what you're dealing with. If you have a procline tooth and you're like, well, I want to take a polyvinyl impression with procline teeth, a lot of times, especially if you're using heavier body silicone, they will jam in there and you're going to end up having to cut that tray to take it out. So maybe for those kind of impressions, use an alginate. I've had good results with duology techniques for frameworks, guys. I'm just saying the way it is. I used to be very black and white, right? I'm like, oh, you can't do final impressions out of alginate. You always have to do polyvinyl because that's the school way. That's the way I was taught. But in reality, the anecdotal evidence, at least, I can definitely see that we've been getting good results with dual algae techniques on things. And as of late, I'll be honest with you, as of late, a lot of times we will take a nice scan of the patient, a partially dentate scan. I can print a nice model from that. You have to make sure you're using proper resin to print it. You can't just use cheap resin to print that model. You have to use a more precise one uh, because a lot of times the labs that at least the lab that I'm using, I'll send them the printed model and they'll make the framework on that printed model. So they're gonna have to duplicate that model. They're gonna have to, you put hot wax on it. So if you got resin that's not very stable, it's gonna shrink, it's going to expand, it's going to warp on you, and the next thing you know, you're not getting a good thing. Or you can just go straight digital design and SLM print that, then model, I guess, doesn't matter at that point. Okay, so there's many different things you can address. So things you need to talk to patients about. Remove dentures 24 to 48 hours before taking final impressions. It's an important step which I don't see very often happening because a lot of patients are very conscious about their dentures and self-conscious without their dentures, right? So taking that out doesn't happen very often. And also, I see this a lot too, right? If patients never take their dentures out, tissue doesn't breathe, and you have denture stomatitis. So you have to treat that before you do final impressions. Okay, make sure you don't have any denture adhesive in there. That's a biggie for me because a lot of times patients don't do that. You can't see it very well, and you can't see it with the impressions very well. And next thing you know, you're going to end up with adhesive in your impression, and it just ruins the whole thing. Okay. Dry tissue with gauze before taking VPS impression. I use it sometimes, not often. Now, if you guys can take a screenshot of this, these are really cool little guidelines for what you need to do in order to capture all the things when you take your impressions. This one particular one with border mold. Okay. And there's the same thing, but for the maxilla right here. So it really, this was given to me years ago from one of the guys from UK, from one of the denturists from UK. Unfortunately, I don't remember the person's name, but I give full credit to them. It's a wonderful, wonderful slide. It makes it really easy to get things where they need to go. Okay. Let's talk a little bit about mistakes, right? Whenever you take in impressions, make sure you're using the proper materials for proper areas, right? So on here you see that majority of the impression was taken with heavy body impression material. That's why you have all these lines in there, because heavy body doesn't really flow really well. And when they try to correct it, they put a little bit of light body in one area, but it didn't do it all the way around. So this impression needs to be redone. Okay. Here they perforated the tray and used light body and it just leaked out. So that's another thing you don't want to do. Don't forget to use tray adhesive. So they were trying to repair and reline for this particular case. They did most of it correctly. They did a nice border molding in the area that was fractured. They tried to use light body or ultra light body in that area where they tried to do a reline. Not the best here, but I kind of measured. We could have went all the way here, but they did not put any adhesive. So when the lab is going to try to pour that up, that's going to ruin that model completely. Okay, so don't forget that. So here's another thing. Whenever we talked about, remember I said, make sure your initial impressions are good. This one, the lingual area was probably too short in the initial impression. The custom tray was too short. And obviously the final impression was too short. Here, they used too much block out. Okay. And now the trays are too wide. And when you have trays that are that wide, you're going to have to make them quite a bit shorter because when you try to do your labial movements, the lip is actually hitting the tray and not allowing to proper border mold it. So you need to take all this area right here and you need to cut that away in order to create proper border mold. Also, if you're doing a light wash, you need to cover the entire area and use firm pressure because otherwise you're going to have steps and bubbles like this. So these things you need to consider. Same thing with lower. I got too much block out, so patient is not able to move the lip in that area and up hitting the tray, and that's why the border is so thick. I often talk to clinicians and I tell them, listen, when your borders are thick on your impressions, that's going to equal thick borders on your denture, okay? And your patients are not going to tolerate that. Yes, you can go ahead and thin those borders out, but at that point, are you making a good fitting prosthesis, because just because you made it thinner doesn't mean it's not overextended this direction. So you need to make sure to address things and look for bobbles, look for the posterior areas. You know, all these things need to be addressed. My favorite thing to do, guys, is reference denture techniques. When you take a patient's existing denture, you duplicate it. Used to be very difficult. We used to have to do it by hand in flasks. Nowadays, you can just easily scan it and print it like this, and then use whatever you want to do the impressions. Now, if you want to do a really, really good job, what you can do is use tissue conditioners. I don't think Hydrocast makes theirs anymore. I think Lionel and Co-Comfort still exist, obviously, but I think Hydrocast has been discontinued. I could be wrong, but there are other brands out there. So you want to make sure you're using tissue conditioner, not soft tissue reline material, because tissue conditioner will set up fully within 24 hours. So if you give your patients these duplicate dentures, put them in Hydrocast or Lionel or Co-Comfort, whatever you're using, have them wear it for 24 hours. They will actually border mold the case for you to give the best possible outcome. If you can't do that, then just use regular polyvinyl. So this is pretty much what I do with, this will be a reline, this won't be a new denture, but the reline impression is the same as the final impression. So I'll put it on there, and if I see overextensions, I will cut it back in those areas, and we'll just do a whole new thing. If you're trying to avoid wasting your, oh boy, what's the word I'm looking for? Your tissue conditioner. You can try to use some ultra light body impression material to double check for overextensions first. So you only have to do that once. Okay. Now, if you have a denture, reference denture that's too short in some areas, you need to build that up with either compound or something else. Okay, as you can see right here, we're missing probably half the denture on this patient, on those areas. This is what I use currently, these impression tray impression beads. So basically, I'll put those in hot water just like I would with compound, and I will put those areas where I need to extend things. Like with this particular patient, I got really good results just by adding a little bit of thermoplastic beading in there and kind of border molding with it in those areas and retromolar pads. So this patient came in with a lower denture that wasn't stable at all, okay? And we talked about it, and I'm like, all right, well, let's take a look at it. So once again, I look in the patient's mouth, just at the tissue, then I put the denture in, and I could see that the retromolar pads are just not in the picture at all when it comes to the denture. So I put a couple of thermoplastic beads in there, we'll border mold it, and what happens is that basically just adding it. We didn't even take the wash impression yet. Just basically by adding stuff to a denture, you get really good retention. Okay, I box up all my impressions like this, guys. I use magnetic boxing tape, which is basically just a white-out magnetic tape that you buy on, not white-out, but dry erase magnetic tape that you buy on Amazon for 20 bucks. I cut the strips, and I'm using R-time dill for the putty, and I just block everything out, box it up, and pour out my impressions. And that way I get the best possible impressions for those things, okay? I like to do the same thing with alternates because that way I can get the best possible impression on things. So as you can see right here, alternate works great with alternate as well. If you guys have any questions on that, you can message me after the webinar. I can try to answer, maybe send you guys some links on what materials that I buy and stuff like that. Okay, if you use that QR code, you can private message me on social media, and I'll try to get you guys those links for later. Okay, so master casts. Okay, also very important, landing areas. I see a lot of crown and bridge labs that try to do dentures and they don't put landing areas in their models. Those are there for a reason. Okay, that makes it easier when you're processing cases, so the cast doesn't fracture. Shows you where the denture needs to end is also a good thing. And it's good for making markings, right, on the side of the cast. So those three things. I try to make the depth of the vestibule about 3 to 4 millimeters, or at least where the undercut starts going in. Okay, thickness of the model, I want it to be at least 15 millimeters, because if it's thinner than that, a lot of times I'll have fracturing when I'm trying to take it off the articulator, de-articulate it, or when it's in the flask and a lot of pressure, those casts can crack as well. This right here, that it needs to be 8 millimeters past the vibrating line, I don't know, guys. I don't always follow this. I guess it's there for a reason, but I've had it shorter before and never had any problems. Okay. Posterior palatal seals are also important. You want to carve those in after your final impression has been done, okay? Because you want your base plates to adhere, to get suction on the base plates on the upper. Because even printed materials, people think, okay, I'm going to print the base plate, it's not going to shrink. It will shrink, guys, especially depending on how you're going to position it in the printer. Uh, if your if your posterior palatal area of your base plates is going to be closer to the build plate of the printer, you're going to have the most distortion there, and you're not going to get the best suction. Okay, but we can talk about it probably in my course that I'm going to be doing next month. It's like a 2-day course, couple hours each day, and we're probably going to have more time. And I'm going to show you some design stuff on 3Shape, probably with things like this, and choose setups and everything else as well. Okay. So obviously these are kind of the basic things you want to know for your wax rims. 20-18. I try to do 80 degrees in the front. Why 80 degrees? It provides proper lip support, because if it's just up and down, it can kind of fall in a little bit. This is another tool that can be useful using papillometer. The way it works, you place it on the papilla and you know how far down to make the wax rims. I usually add a couple of millimeters to that measurement because you want to make sure that you can correct the horizontal plane afterwards when that's done. Obviously, lip length when you're doing try-ins is different. You can have male versus female, young versus old, so all of that needs to go into the account. Something like this is a useful tool also. Let's say, for example, you're trying to mimic an old denture, but you're not duplicating that denture. You're just going to use that for the wax rim option. You can use that papillometer, and it's oh no, it's not papillometer. It's called Alma gauge. Sorry, guys. Papillometer was the previous one. Alma gauge allows you to see the vertical and horizontal position of the interior teeth in relation to the incisive papilla. Okay. I've made one myself, actually, a digital design that you could stick on one of these uh, digital calipers that are like $5 or $10 what they cost, and it works the same way. Okay. That file is actually available on my Thingiverse account, which you can download absolutely free, and you can print it and use it if you want to. The reason why I don't use this very often is because majority of the time, guys, I end up using this and making a duplicate denture out of it and using it as my custom tray, because I can skip a few steps doing it that way. Okay. All right. Wax rim, you want to make sure that it's on the ridge. You want to make sure you have proper dimensions, as you can see right here on the maxilla and the mandible. The reason why I like using these yellow wax rims from Gebdi is because they already have those measurements within what they need to be. I don't like buying those really wide wax rims and just adjusting the crap out of them. I used to roll my own. I mean, wax rims. I used to roll my own. And it took a while, and it was just kind of, I like this one because it smells like vanilla. The yellow color makes it easier to see where the lip location is. It's just all in all a good design. Obviously, it's going to be more expensive than just regular wax, but it's up to you guys, whatever you want to use. This right here is my favorite tool. I absolutely love using this tool. It allows me to properly adjust wax rims, not just in the lab, but chairside as well. This little lip right here is awesome. Basically, what you do is you actually place that little lip on the handle or notch, and you move that. A lot of times you'll see they'll use that with a spackle tool or whatever. You just go up and down, up and down. This allows you to follow the hip mount, hip plane, which is close to a camper's plate. So basically, you measure 22 millimeters from the depth of the vestibule. You place this down on the handle or notch, and you push down until you get to that 22 millimeters. And you just smooth that out, and you're good to go. And a lot of times you're right on the camper's plane when you're adjusting a chair set. Okay. So on the lower, you just reverse things, and you move it out with 2/3 retromolar pad and 18 millimeters in the front. And same thing, you just go down to make it easier. Now, for this particular case, you can see like Doctor took a decent impression, but they used heavy body impression material, so it kind of pushed things out of the way, and you don't see a lot of definition of things like this, and things are a little pushed out. And we're not going to just start over with this. We're going to take a step. We're going to pour that up. You can see right here, we're kind of pushed out as well. And what I'm basically going to do is I'm going to make the wax rims, but I'm going to trim the wax rims back. Because usually wax rims go to the border of the what? the base plates, I mean, go to the border of my landing area. But in this case, I've actually shortened it because I think they're overextended and I think I don't have really good detail. So basically, I'm going to make wax rims, but the doctor is going to be able to take those wax rims and actually take some wash impressions with them. Okay. On here, with these wash impressions, let me go back. Wash impressions on cases like this, I like to do them at the try-in stage, because if we take a wash impression at the actual bite registration stage, I'm going to have to make whole new wax rims here. Okay. And I don't want to do that because it's going to bring up cost for the client as well. So a lot of times we'll do the setup, do a try-in, and then we'll take a final wash before processing. Okay. Gothic arch tracers, guys. We used to just do these ones where you had to buy a whole kit, and you could just use them on one patient at a time. Then you have to sterilize them, reuse them. Kits were like $100. Then I actually designed something look like this, where I can actually take a metal part and attach it to there. But the last design we actually started doing just printing everything on it. Now that explanation to how to do that is actually online, as well as all the parts for the Gothic arch tracer are also on Thingiverse. You can download it, watch the video. There's two videos, one in Russian, one in English. Just pick the one you actually understand. And it shows you how to fabricate those for your patients. Okay. And I really like doing those cases because it allows me to get the best possible outcome for my patients to get the centric relation, especially if we don't have a stable bite. Okay. Let's say we have a patient that comes in. They have an existing set of dentures, but the posterior occlusion has worn down, and now all of a sudden we don't have really good occlusion. Okay. And if we kind of just use that to take the impressions as we did right here and take a bite and try to set up the same bite, it's not going to end well, because what's going to happen once we have good posterior occlusion in that relationship, patient is going to realize they can occlude on their back, and they're going to deprogram and relax. And next thing you know, you're going to have this, okay, anterior open bite, just because they're back into their centric. So in cases like this, I'll cut back and I'll actually put a Gothic arch tracer in there first, capture that centric, and then we'll do a setup. This is just a different version of this where you can actually take a wash impression, snap this in, and then do a centric relation. You can do also phase bows. I don't like using phase bows. They're just, one of the reasons is this, because the external ear canals are not always on the same level. With me, they're okay, but some people are like this, whatever. I think using voice analyzer works great. I've made my own before. For some reason, what the heck was that? It was just kind of jumping. One bite makes something like this, or you can just do the old-fashioned stick bite. Especially, the reason why those are important, especially if you're doing a immediate denture and teeth are all over the place and you want to communicate the proper horizontal plane, so that works well. Or if you did a wax rim and you kind of adjusted the wax rim improperly, and all of a sudden you have a cant in your wax rim and you want to fix that. So you can provide a stick bite to your lab and they'll set it up properly. Things like this. You need to be able to mark things on your wax rims for the lab. So marking the canine lines, marking the midline, the high lip line, all those things are important. Okay, so model analysis. I'm going to go quickly through model analysis, guys, because, well, actually, let me go quickly through occlusion, and then we'll go back to model analysis because I'm afraid I'm going to run out of time. So let me just skip a few slides here. So basically, guys, when I'm setting up teeth, in order to get the best possible results, this is my method of doing it. What I basically will do, I'll set up my 6 anterior teeth and my first bicuspids on the maxilla first, using either a table. Most of the time I'll use a table that I mount to, or you can use a silicone key if you want to. Okay. Once I've set that up, the reason why I'm using my first premolar here, because it's going to allow me to set my lower first premolar, and from the lower first premolar I can actually set my plane of occlusion to the retromolar pads. Okay. So as you can see right here, I'll set up my lowers and my lower first premolar, and from there I'll set up all my lower posteriors. So I got my proper plane of occlusion going halfway up or 3/4 up the retromolar pad. And then I'll set up the rest of the upper posteriors, guys. From here, I start checking my working and balancing. I always try to set up and lingualize. My favorite teeth to use is the ones that I've been using for a few years now, are VITA pen XLs and linguiform posteriors. Those are the teeth that I use for my premium cases and all my implant cases. Okay, for my economy teeth, I use MFTs, which is also a great tooth. It's sold as an economy, but it's more of a midline tooth, so I really like using it for my economy cases because it lasts. It definitely lasts. Okay. So here we have centric, or here we have balancing actually. So you can see my interiors are occluding. We don't have any occlusion here on the buccal because it's lingualized occlusion, and we just have occlusion, or at least one tooth to two teeth on the balancing side. Okay. So really aesthetic tooth, really like doing it. I've heard some people complaining like, I don't like these little lines on the teeth. They're not great for plaque biofilm adhesion. Honestly, guys, I don't have usually issues there. I mean, we'll have issues in the proximal like everybody else does, but this right here doesn't usually adhere things, and it really breaks up the light nicely and gives you a very, very nice appearance. If you don't like it, it polishes out really easily. So just when you're polishing your acrylic, just go over the teeth. You'll take out all that anatomy as well. Okay. Okay. So that's for the occlusion. Now let's go back and talk a little bit about model analysis. Sorry. Let me just go back up here because I want to make sure I got plenty of time to get things done. That's why I want to talk about occlusion first. Just so I don't end up like going through model analysis and then just cutting you guys out and go like, how does he set teeth? Because he said he was going to talk about setting teeth. I'm going to go a little bit more in depth on it on my next 2-day webinar, but we're going to talk on the 2-day thing. We're definitely going to talk about this again, but the other things as well. As I said, like digital and doing stuff on with 3Shape and everything else like this. All right. Model analysis. Oops. Sorry, I pressed on the wrong. My apologies. That's what happens when I try to move stuff around. All right. So generally, we try to follow model analysis kind of started and designed by Professor Gerber. You can see it can get pretty complicated. And I'm going to show you a little bit of the complicated way, and then I'm going to just show you the simpler way of how I do things as well, right? So basically, you're going to have cases, right, where you're going to have your aesthetics in one position, but your function in another position. What basically model analysis tries to do is to minimize issues between aesthetics and function. So it allows you to place things as far out buccally, but without tipping the denture or fracturing the denture. So and to eliminate cross bites. Okay, so your models need to be mounted. You mark the crest of the ridge. You mark the incisive papilla. You mark your tuberosities. And here we can see that 7 to 8 millimeters from the incisive papilla is where your incisal edge is going to be. Now that's more for reference, and especially when you're doing wax rims, like, oh, how far out should I put the wax rim? Well, look at the incisive papilla, measure 7 to 8 millimeters from there, from the center of it, and that's usually where the incisal edges are going to be of your teeth. Okay. Now, if your teeth are set too far, and you're like, well, where should they be? You can measure it there and go, oh, maybe we should need to move it 2 to 3 millimeters back. Okay. Obviously, use common sense. If your incisive papilla is not matching up with your Rafni Palatini, you're probably not going to be able to do very successful model analysis. Okay. Your midline needs to be maybe adjusted, or you need to aesthetically double check it and things like that. Okay. So we're going to mark the position of your canines anatomically with a setup. The way you do that, and I use that very often because a lot of times the doctors will send me a model with a wax rim on it, and I'll mark the midline and nothing else. So how am I supposed to tell which mold I should go with? And a lot of times the wax rim is maybe not properly adjusted, so I can just measure like where it turns and stuff like that. If you look on the palate, and if you have a good impression of your maxilla, you should be able to see the first major pair of palo rugae. Okay, that's where from the tips of those major pairs, you go outward. That's where it's going to bisect your canine. Okay, so that's a really good way to kind of mark things and to pick a mold for your specific case if you don't have those markings. Now, the last major pair of palo rugae is where you have your first pre-mold. I don't often see those things, and I don't often use them, to be honest with you. And I'll explain to you here in a minute why. Okay, so there's things such as like static lines, inner correction and outer correction. Static line is the ideal position of the tooth. For the maxilla, the static line is the ideal position of the palatal cusp of your second molar, of your first molar, and your second premolar. Okay, because you mark it from the center of the tuberosity to the center of the first premolar. Okay, and that line is going to give you ideal position of your second premolar palatal cusp, first molar, second molar. Okay, hope that makes sense, guys. Now, if you have to move teeth inward, which I've never had to do, because why? Well, teeth are generally need to be moved outward on the maxilla because maxilla will resorb inward and up. Okay, so we want to try to move teeth outward to close those buccal corridors, not inward. But if you needed to, you mark the pterygomandibular fold of the first pterygomandibular fold area, which is right next to the hamular notch, which is like 1 millimeter to 2 palatally from that, and you draw a line straight through the first premolar. And that line is how far you can move teeth inward on the palatal cusp in order to achieve what you're trying to achieve. But from personal experience, guys, I never had to do that. Okay. Now, the outer correction we had to do before, right? How far out we can move the end. And for that, if you're dealing with the palatal cusp, you're going to mark the outer line of the tuberosity through the first premolar. Now, to me, guys, that's a little bit difficult because a lot of times the position of first premolar is not visible, okay, very well because we don't have that last major pair of palo rugae. We'll kind of have to approximate things. But the easiest thing to do is we have our buccal vestibule. And we know that the buccal cusp, sorry, I got an itchy nose. I don't know why. There's an old Eastern European saying, if your nose is itching, that means you're going to get drunk that day. So I wasn't planning on it, but I guess I'm going to have to now. But I digress. We know that the buccal cusp can go to the depth of the vestibule on the buccal for us. Sorry, just for some reason I got frazzled. And for me, that's the easiest thing to control. Like, how far out can I move the teeth buccally? Well, we're going to look at the buccal cusp, look at the depth of the vestibule, don't go past that. And usually that will still have the palatal cusp on the ridge, and you can still engage that and still be with a stable there, okay? Here is a fancy way of marking the lowest possible point of on the mandible. And according to Professor Gerber, that's where you're actually going to place your first molar, okay? So basically the models are mounted, and you can actually transfer that lowest point to the upper side to mark the position of the first molar in class 1 occlusion on the maxilla in accordance to the Gerber setup and Gerber model analysis. Since I don't do Gerber setup, that right here I don't use. So the difference between Gerber lingualized occlusion and regular regular lingualized occlusion, I guess is the word I'm looking for, is Gerber lingualized is tooth to tooth like this, okay? And regular is tooth to two teeth on your molars especially, okay? That's why this one worked for my setup. So I got the deepest point right here, and the corrections are going forward, how much forward I can actually move my molar. 2 millimeters this way and 2 millimeters this way, according to my model analysis. Okay, very complicated stuff, guys. I don't generally use all of this. I'll show you a much easier way here in a minute. Okay, but the idea, you also try to find a line that matches 22.5 degrees, which is an average of resorbed ridge and plane of occlusion angulation. So they did a bunch of research and they found out that this, how your plane of occlusion relates to your resorbed ridge. And if you put it at 0, the area where it starts to bisect that line of the crest of the ridge, which you transfer over to the side, which if you go back right here, this is what we use. That's little specially made tool to get that done. Or you can just use the regular compass with a little bit of raw wire in it. So that will allow you to transfer those marks on there. And as you can see right here, the area where it starts to bisect, past that point, we're not placing any occlusion. But that's the most precise way of doing it, okay? But on here, well, first of all, what if we have a nice and flat ridge? How do we do that? Where do we stop occlusion? Well, if you have a flat ridge that doesn't have a lot of differences to it, stop occlusion once you get to the retromolar pad. We don't put teeth there, right? The reason why we do that stop occlusion thing is because once we start getting past this point of stability, all of a sudden you no longer have just vertical forces, you have vertical and horizontal. You kind of change direction, or vectors, I think is the word I'm looking for. And it will actually destabilize the denture. That's why you try not to set teeth too far back. That's also why a lot of times you'll see two setups, especially mine, where I'll drop a premolar and have two molars, or I'll drop a second molar and have two premolars and a molar. That's because I'm trying not to go past that point of stability, guys. Okay. So the way they teach us to do this also, crest of the ridge, retromolar pads, mark halfway up the retromolar pad. Here we have two lines. Now the depth of the vestibule on the interior is how far out you can actually angle your anterior teeth. Now the crest of the ridge, which is marked in black, is still where the teeth are going to be sitting, but the angulation of the teeth can go to the depth of the vestibule. You can't go past that point because you're going to destabilize teeth, okay? So fairly important points. Now slightly behind the buccal frena is going to be position of your first premolars. And you're going to do the same thing. You're looking for these lines that are going to be like, oh, this is the ideal line, this is not ideal line, things like this. So basically, if we mark a line through the center of the retromolar pad and through the center of my first premolar, that's going to be ideal position of our central fossas for the second premolar, first molar, and second molar. Okay, that's the ideal position. Some people will be like, well, how do we mark it if we don't have our buccal frena? How do we mark the position of our first premolar? Look at the crest of the ridge. Where it starts to bend right here, that's usually going to be the position of our canine. Slightly behind that position, just take a measurement, 2-3 millimeters. Past that position is going to be position of the center of your first premolar. So you can do that as well. Okay. Now we're going to look how far out we can move teeth. Okay. So we're going to take that same position of our first premolar, but we're going to go not through the center of our retromolar pad. We're going to go through the buccal area of that. That's how far outward we can actually move the central fossa of our second premolar, first molar, second molar, okay? And now if we need to move things inward, same position of the first premolar, and then we're going to go through the buccal area, buccal margin of our retromolar pad. If that's not visible, you can actually use the mylohyoid ridge as a guide for that as well. So you have three lines, right? The ideal, the buccal, and the actual lingual, where you can move things in order to get the best possible aesthetics and also get to avoid, possibly avoiding crossbites, okay? Now, obviously, if you see a situation like this, where the crest of the ridge is right here, and the actual retromolar pad is right here, now that means you had some kind of distortion or maybe anatomical abnormality. Now you can no longer do that. You just have to go through the crest of the ridge, okay? Now, this is a slide from the actual Mertz company, and they kind of explain it a little bit more in detail. But you can kind of see right here, right? So we have our center of our first premolars on both top and bottom, and that's where the lines start to originate. And we have our ideal parallel lines, and we have our corrections outward. Now, this one is marking not the correction outward on the tuberosity, but actually marking it like I showed you guys on the buccal frena. But this one is actually marking that line on the using tuberosity in the first premolar. Okay, so you can see these things. You could see those things. Sorry, but ideally you want to go through the center. Oops, sorry. Ideally you want to go through the center, or to bring it outward. So here we know that we can move that tooth a little bit outward if we need to. Boy, why am I? What's going on? Sorry, I had it on the wrong screen, and when I click it, it just does this. Okay, on the lower, same thing like I showed you guys. We got the first premolar, we got the ideal lineup for central fossa, and we have the areas how much we can move the central fossa outward and inward. Now be aware, guys, if you have a ridge that's a knife ridge, right, and you can barely move this direction and that direction, maybe model analysis is not important, right, because you can only move so much. It's not going to make a difference within half a millimeter to a millimeter. But if you have a nice broad ridge, yeah, that definitely makes a difference. Okay. Another thing I wanted to mention, guys, when you are doing that little depth of the vestibule, let me go back. I'll show you what I'm talking about. Okay. So this is the complex way, and it looks like, well, this is going to be my ideal position, and that's where I'm going to have the stop line and stuff like this. Basically, I don't even trace things anymore. I look on the side of the ridge, and you can see the lowest point approximately, right? You can see like, oh yeah, that's the lowest point. So I'm going to put my molar within that area. So what do I do in order to accomplish that? If I need to drop a premolar to have my molar more forward, I'll drop a premolar and move it more forward so I'm within that deepest point. If I need to move it back, I'll have two premolars and maybe a molar in that area, okay? And then where do I stop my occlusion? Now you can go all fancy and use these things and all that stuff, and it's great and it's more precise. Or you can just look at the crest of the ridge, and where it starts going up sharply, don't put any teeth there. That's usually a good rule of thumb of doing things, okay? So we covered, hopefully, we covered all the impression stuff, all the model fabrication stuff, all the myostatic outlines so we can make nice custom trace. We talked about final impressions and things to watch out for there. We talk about the way I set up my occlusion, which I use lingualized. And we talked about where we place teeth according to that occlusion with model analysis. So those are the things that I wanted to cover today, guys, and hopefully I've done that. And now we can actually take a minute and answer some questions.
Thank you, Eugene. Appreciate it. That was very thorough, and I think it gave everyone, both whether they're digital and or traditional, a lot of insight on how the basics, the fundamentals, what they have to look at. And I think you know we can all use that information. Let me show you. Let's see here, everyone. So CE, those questions on CE, you're going to receive an email, and we'll provide those CE credits through the registration that you used. The workshop was recorded, so visit us on the VITA North America YouTube channel. And then we have, as I mentioned, we do have some additional webinars scheduled throughout this year with Eugene and others, so please visit us. If you need to get a hold of Eugene, Eugene's been providing us with his information, contact information. So please visit him. Just reminder that he is a working commercial laboratory, and if he doesn't get back to you, of course, that might take a few days or so. So make sure that you give him time to respond. As far as questions, so let's go. Can you share again the image with the lower limiting structures, please? So if you want, what I can do is give it back to you, Eugene. I'll give it back to you if you want to find that picture of the lower limiting structures on the treatment planning.
Now, if you message me, I have a PDF that I can send you guys that has all the steps on how to properly do myostatic outline. It's not my PDF. I found it online, so it's written by somebody else, and that's where I learned it from. Okay.
All right. So let's see some other questions, Eugene. For the maxillary digital scans, do you capture the extension that you showed on a traditional in the palate, the extension of the palate, or is it not needed for a digital scan? How far back do you go on scanning on the
So
Mac?
the way I view impressions versus scans, um, I don't make that distinction. I think all the anatomical landmarks that are required in order to fabricate a custom tray need to be present on the scans as well as the impression. With that being said, there have been times, more than I'd like to admit, where I would get a scan that's missing quite a bit of information on the palate. And what I'll do is I'll go into MeditLink, and what I'll probably do when we do I think my course, let me just double check the date. I think we're doing it on the 20th and 22nd of August. I'm going to show you guys how to, in MeditLink, maybe split those little areas to fill in those gaps so you can make a somewhat closer fitting custom tray. But yeah, the idea is you want to make sure to capture as much information as you can with a scan so you would match up. Same thing without.
All right. Another question was kind of related to what you just mentioned was on the custom tray. Do you ever provide a spacer for the border, vestibule border area?
So what I basically try to do is I try to make the closest fitting trays possible. So basically my outline of the custom tray is going to mimic almost a base plate. Okay. I will put usually a 1 mm spacer that's made digitally in there, and I'll put like 4 tissue stops. And that gives me that space away from the tissue and away from the outline. Okay. And that allows for the material to fill in those gaps and also give me a little bit of border molding. I wouldn't call it border molding, but gives me that area where it actually can envelop the material in the vestibule area. I don't know if I said that properly. Sorry.
And then another question on your final denture, how thick do you try to keep your final denture design? Like maybe in the palate area or the
On the palate, so it depends on if it's on a soft tissue where the posterior palatal ciliary is. So the denture base on the palate is usually 2 mm thickness. But once it starts getting to the posterior palatal ciliary, I start to knife edge it because I want that nice transition from the denture to the soft palate where the patient can't feel that step with their tongue because a lot of times it will actually make them gag. So I try to thin it out as much as possible in the area. But the thickness in the palate, I try to do 2 mm.
All right. And then when you do dentures, a tissue supported denture, whether it's with or without implants, do you terminate the border any differently? Like if you're using attachments, I guess would be an example.
So it's highly dependent on the type of attachment that you're doing. If you're doing a locator type of thing, or you're doing a borrow over denture, which is not a hybrid type, not a wraparound hybrid, but you're doing something that's going to be ridge lap, I want to make sure to follow the same adaptation as I would do with a regular tissue supported case. Because what it's going to help me do, even though my retention is going to be coming from the implant components, and support is going to be also coming from implant components, I want to make sure it's properly extended so I don't end up trapping more food in there than I need to. Okay.
And then have you had patients that, for whatever reason, their denture seems to stain more than others? And if so, do you have a cleaning protocol?
Absolutely. So I definitely have those patients, especially a lot of people from certain areas have different diets that we do. And for them, they'll have more curry, for example, or they drink more tea. Like people from Central Asia or Middle East, they have a lot of they're heavy tea drinkers, and that stained denture is a lot more. So what I use, I actually use a Simpro machine from Renford, and it allows me. It's got like it rotates. It's got little needles in there and a magnet, so it just kind of keeps the needles with that magnet. And you put their solution in there. So they have their own solution you could use for stain remover, or you can use probably other ones if you wanted to. But because of it's a chemical and a mechanical process, it usually cleans that up pretty well.
All right. Well, that wraps us up today with the questions, and I'm sure you have some other questions for Eugene. Again, he's been kind enough to provide us with you his information. You can see it on the screen. If you have your phone, you can take a screen capture of the code and have a link. Eugene, any last minute comments you want to make for the attendees?
Yes, if you guys, I just want to remind you again, if you guys have questions, I already have some people messaging me right now, but if you have questions, don't hesitate to ask. I love sharing. I love helping people out, because if I can make your life better, maybe you'll make my life better too, easier a little bit down the line, because some of you guys are clinicians, some of you guys are lab techs, and we might be working together, or you might be working with somebody else, and you can maybe pass on that knowledge to them, and we can actually make the whole world a little bit easier for us to work with. Because God knows we're dealing with enough problems every day already. Don't need to make it any more complicated. So yeah, feel free to reach out and have fun with it. I guess that's all I can say.
Yeah, for those of you that are attending, Eugene's got a great deal of education himself, working as a denturist. He does perspectives from a clinical side as well. So he's got a lot of insight on how maybe he can help you communicate with a dentist if you're having issues on how to resolve some issues and so forth. So I want to thank everybody for joining us today. Eugene, I appreciate all the time that you've taken out of your day to do the webinar. Great information. We look forward to you later this month in August 22nd, 24th to do a two-part series of all this, kind of wrapping it all together.
Yes.
I encourage everyone to visit and register for that webinar. It's two-parters. It's still, each one's an hour, hour and a half each day. It's on a Tuesday and a Thursday of the same week. So you're going to get a lot of information during that week as well.
And we're going to try to do more digital stuff there as well, just so you guys are like aware, like, oh, okay, well, what can I do to fix this model, or what should I do to fabricate this custom tray, and maybe how to do a setup digitally. All those things that we're going to try to incorporate.
Great. That'll be a great walkthrough for everyone. So I hope you can join us. Eugene, thank you again very much. Everyone, I want to thank you for registering and attending. And this will end today's webinar.
Take it easy, everybody. Bye. Thank you.
Bye. Thank you.